We'll have Dr. Vivekanandan, who will be speaking on managing iridodialysis.
Good morning, everyone. Thank you, Srini sir, for giving this opportunity. So I'll be talking about iridodialysis and how to prevent them intraop and the management. So in cataracts like this, when there is no epinuclear bowl or cortex, black cataract, and we are doing an SICS or an ECC, there is a high chance we can do a iridodialysis because we don't have enough space between the nucleus and the iris. So here the choice of viscoelastic is very important. If you use a HPMC or a lighter viscoelastic, you are not going to create much space. So it's better to inject something like a dispersive viscoelastic so it stays in the eye. Make sure it doesn't sandwich. This is something that you should not do. When you have an iridodialysis, don't do this. So how it happens is your vectors get sandwiched between, the iris gets sandwiched between the nucleus and the vectors. So make sure you use a lot of viscoelastic, create some space, and then deliver it. The second one, in phacoemulsification, I think iridodialysis happens because because of our ego. So when you have a patient like this who has IFIS, these are things that you shouldn't do. This is a probably a decade-old case where I tried a stretch pupilloplasty in this case. The pupil did dilate, but it is very floppy. It's very important to take history of what the patient is doing. When you have the iris, getting caught in your probe, it is always best to stop surgery, put in iris hooks and then continue. This is something you shouldn't do. Later on in this surgery, when we realize that it's too bad, the iris is trimmed, iris hooks are placed, and then phaco is done. So always better to do it in the beginning of surgery rather than having problems like this. One other thing is, you will have an intraoperative meiosis. You will start with a 7 mm pupil and then on table it might go up to 3 mm, 4 mm. There will be a lot of fluttering. So in these cases, what you have to be aware is, since you have done the rhexis already, make sure when you are placing the iris hooks, it's always better to place any pupil expansion device before the starting of rhexis. In case you started after rhexis, make sure you inject a lot of viscoelastic between the iris and the anterior lens capsule and then anchor your iris hooks, because there is a high chance you will pull the rhexis margin and you can tear it also. Even, not just iris hooks, even your Malyugin ring or any other pupil expansion device, you have to be aware of, the rhexis being there. So inject a dispersive viscoelastic, check with your Kugel hook and then anchor the iris points. And this is just to show, this is a pupil expansion device that I designed along with our lab. I have no financial interest, so I just want to show this also. So this is one device, which encircles the pupil 360 degree. It's made of silicon. It holds the pupil and it gives you a round pupil called the iNova. And so such devices can be used so as to prevent an iridodialysis. Moving to iridodialysis, I don't have a video of intraoperative iridodialysis, but I'll show you my technique of managing an iridodialysis. So in this particular case, it's a traumatic cataract. So where there is 4 clock hours of iridodialysis that you can see on the nasal side, I make the incisions, I stain the capsule, and then I make an incision right in the middle of the area of the iridodialysis. This is mainly to insert the iris hooks so as to keep the iris from getting caught into the probe. So once the iris hooks are placed, I complete my phacoemulsification. I'm just not finding the cursor. Okay. So once the iris hooks are placed, you complete your phacoemulsification, and then you can place the intraocular lens in the bag, assess the zonular weakness, depending on that you can do all that. And then after removing the iris hook, I make paracentesis so as to facilitate my second instruments going in. And then I remove the HPMC from the eye because HPMC tends to roll out the iris tissue. I use a combination of sodium hyaluronate and a dispersive cohesive combination so as to flatten the iris. And at the level of iris plane, I use a spatulated needle attached to a 70 proline suture. I move the conjunctiva radially before making the sclerotomy, and then the peripheral iris tissue is held, and through the paracentesis or the clear corneal incision on the opposite side, the needle is held and it is brought out. So once it is brought out, the same needle I reintroduce through the same paracentesis or the clear corneal incision. In the similar fashion, the peripheral iris on the opposite side, where I have to anchor, is held, and using the same needle suture, it is pierced, and then it is brought out of the eye at the level of the iris plane. So one thing I recommend everyone to do is do a peritomy in the initial days. Once you're comfortable doing the procedure, move the conjunctiva tenons radially before you make that, bring the needle out, so as you don't have the scleral opening and the conjunctival opening at different sites. So now you have a loop inside. Once you have a loop inside, all you have to do is pull the sutures coming out of the sclerotomies till you get proper approximation. Once proper approximation is there, trim the suture to about 1 millimeter, and using your low power portable cautery, create a small flange. So first, after one flange is created, all you have to do is pull the suture on the opposite side. While doing so, pull the conjunctiva tenons surrounding the flange so as to bury the flange below the tenons. And once it plugs the sclerotomy, trim the suture to about 1 millimeter on the other side, and then you create the second flange and bury it. Sorry. And then wash the viscoelastic. So probably in the initial days when you are trying to do this, I would recommend doing a peritomy. So this is a technique that I would design. The conventional way, you can do a Hoffman's pocket and bury the, take multiple bites. So this is a little simpler version of IRD management. Thank you.
Thank you. A very nice presentation, Vivek, and it's a nice way to see that flanges which are invented for IOL now we are using for iodialysis.